My name is Joe Pye. Here with a colleague of mine. Excuse me, I just had a cold. I'm here with a colleague of mine, Alex Milliken. Alex is the clinic director of the methadone maintenance treatment program, opioid treatment program at Discovery House in South Portland. He's been doing that for a lot of years. He has a lot of experience in the community, homeless community, and he and I, my name is Joe Pye. I'm the medical director of the clinic in South Portland and in Waterville. I'm an addiction medicine specialist, and I've been doing that for about 25 years. We're gonna hopefully discuss, not just lecture to you, but discuss some of the things that we think are important myths to be busted, I guess, when it comes to our modality. We're the other medication-assisted treatment, but we're about 50 years old. So before we get started with that, I really wanted to thank the University of New England and the planning committee from the University of New England who put this all together, and Portland Community Health, and all of the other sponsors that have put this together. So it's really, I'm very impressed with all of the presenters and what's been going on so far. So before we begin, I'd love to have us give a little clap for the people who put this together. Okay, the next part, not to elicit your performance anxiety at all. We're gonna do a pre-test quiz. And so what I wanna do is I'll read each of these, and what I would like you to do is put your hand up and when I say, is this true? And if you think it's false, put your hand up. And then we're gonna proceed with the talk. Okay, so the majority of the people in our methadone maintenance treatment program in our South Portland clinic are people that have been in treatment for over 5 years. How many people think that's a true statement? Okay, how many people think we're making that up? How many people don't know whether it's true or false? Yeah, okay, all right. So, people who are opioid dependent, opiate dependent, I mean, there's all kinds of, all kinds of definitions, all kinds of terms that are used. In Pennsylvania, they use narcotics still. It reminds me of the Untouchables, Elliot Ness, and they talked about narcotics, but we're gonna try to use the right terms. So, in our clinic in South Portland, people who are opiate dependent or are in treatment are more likely to be younger. Younger than what? I know you're asking, but they're younger people than older people. How many think that we have young folks in our clinic mostly? I would say younger than 30 years old. No one. Okay, all right. How about older than 30? Yeah, okay. So males are more likely to be getting treatment at our treatment facility in South Portland than females. How many people think more male predominance? Okay. Female? I'm not going to give it away. Okay. Once people come into our treatment program, they stop using their opioids. Okay, one person thinks so. 2 people. Okay. People in methadone maintenance treatment continue using illicit drugs. How many people think that that's true? Okay. How many people think that that's not true? All right. We'll see. So I'm going to stay down here because it's easier than being up on stage. There's not much room with the slides, and Alex will take it from here. Oh, one more thing, sorry. If you have questions, it's okay for you to ask them in between the slides, and then we'll still have enough time for other questions or discussion, okay?
Okay, thank you for being here, first of all. When I was first invited to make this presentation, I saw it as an opportunity to address a lot of the misconceptions that about methadone treatment and how we treated Discovery House. Over the years, I've made sure to read the comment sections in the papers. Anytime methadone overdoses, anything like that, and they're pretty consistent as to what they say about what they think we do. So let me first, a slight disclaimer. The data I'm going to present here is from Discovery House in South Portland. We're fortunate that we have a really good set of software, and I can gather lots of data. Some of it was kind of tedious, but that's okay. It shouldn't be interpreted to represent other clinics or the treatment modality as a whole. We see people from all over the country who come to Courtesy Dose. Some of the information that I'm going to present today is pretty consistent with what we see in those courtesy doses, because we know what patients' doses are. And, in some cases, we know how long they've been in treatment and stuff like that. And like Dr. Pai said, any questions, let me do my little spiel with the slide and then raise your hand and do it. We don't want to miss questions. So, did it right. These are the things I saw, these are the things I see in the paper. Once they come in, they never go. We won't let them go. We keep them forever. They're all on main care. The state's paying for everybody. They continue to use drugs. We don't test them. They're all on high doses, and they don't do any counseling. Almost every single time methadone is mentioned, those things are mentioned, along with the social Darwinists and stuff like that, which is the thing that aggravates me most. So gender, 664. We have an opioid health homes, and they're in the same piece of software as the methadone program. So you'll see varying numbers. Sometimes I left the health homes in because it was just too difficult to take them out of that because it reports the stuff as a whole. So 664 patients, 323 were male, 341 were female. We have a buprenorphine program as well. At one point, we had 130 patients in that, and over 90 of them were female. That was really skewed toward the female side. Some of that was because they were a bit higher functioning than the men who were applying, so they were more appropriate for buprenorphine, because we've tried to not treat people with buprenorphine who just weren't going to succeed. And some of the drug histories of the male patients who were applying were just too much for the buprenorphine. Age. 20 to 29. We have nobody under 20 right now at the clinic. You can't be under 18. We have nobody under 20. 89 patients are between the ages of 20 and 29. 376 between the ages of 30 and 44, and 199 are over 45. Primary cause of death of patients at the clinic has basically, for the last 4 or 5 years, been health related to age. And a lot of those patients had been in treatment a long time. It's one of our better statistics is that they were able to stay alive long enough to die of something other than a drug problem.
Yeah, and I would say our elders, we rarely see people that are older than 60.
We probably have maybe 7, something like that. Most of them were direct referrals from doctors. So, length of stay, 288 of the 664. And these numbers, like I said, may not jive. This may be one of the ones where I could take the health homes out. 288 of them have been there for less than a year. Every year we discharge over 300 people. Not all of them successful, most of them by patient choice. The only patients we will dissuade from leaving are the ones who are continuing to test positive for opiates, and that's because what's the point in going right now? You're still using, you're going to come back shortly thereafter. 137, 1 to 2 years, 143, 2 to 4 years. That's usually when people leave successfully, is after 2 years. They've normalized and stabilized their lives. They're working, they have housing, they have what they need. And 91 have been there more than 4 years. A lot of those people tried to taper out at one time or another and were unsuccessful and now do not dare to. Some of them have chronic health problems, usually pain related. They can't take pain medication safely without methadone treatment, so they stay. Most of those people you see on fairly low doses. Insurance. Right now we have 96 patients, that includes the opioid health homes, who are uninsured, that we have a grant program with the state. 7 of them are treatments being paid for by the Veterans Administration. 191 are private pay. That's self-pay and insurances. We don't have very many insurances right now. I think there's a total of 44 patients who have their own insurance. That number was much higher 2 years ago. There's been a pretty steady decline since the Affordable Care Act has been changed. And 376 are on main care. Drug testing. So 5,817 tests were performed as of August 30th, 2018. Of those 5,817 tests, 3,177 tested positive for all drugs. So that means if you did anything, that includes marijuana. So it's close. 54.6% tested positive for something. Some of those can be a little bit skewed because they had a prescription but didn't turn it into us, so it shows as a positive. If I take out cannabis, 1,744. Where's my percentage? It took away my percent. Oh, there it is. 30%. In the next couple of slides, something to consider is this includes new patients who test positive, usually at least the first test, usually the first 2, sometimes 3 tests before we get them to an appropriate dose, and it's the medication is working for them. Opiates. 4,852 patients were tested for opiates, 419 tested positive, and like I said, that includes the intakes. This year we'll do over 400 intakes. I think my estimate was 430 something. So almost all of them stop. It's the ones who aren't motivated discover it's pointless. That once we get them to the right dose, there's no point in it. They can't feel it, or they can feel it for just a couple of minutes, so they stop spending their money on it.
And typically we're seeing that drop in about the first 1 to 3 months.
Yeah. Usually the opiate positives go away in 2 months. Sometimes it's as early as their second test it's gone. That depends upon how good they are at getting there and how good we are at getting them up to a safe dose. One of the really difficult things about what we do is we need to get them to an effective dose as quickly as we can, but we need to do that safely. So there's some corporate influences who worry about us bringing them up quickly. There's us at the clinic who know that people generally aren't harmed by, the quicker dose increases. Induction was a really soft subject or touchy subject for a long time, where it was considered a really high-risk area. But I've been at Discovery House for 11 years, and I haven't seen. I think I know of maybe 3 people who died from an overdose that were in the induction phase, and 2 of them were very clearly related to benzodiazepines, that they'd taken too many. So cocaine.
Hang on a second. So it mentioned the induction period. So we kind of, for our convention, break up the first 2 to 4 weeks that we have someone in treatment for methadone. We call that the induction period. That's the period of time that we have to watch them most closely. And that's the time, because the methadone is so long acting, the people that come into us are using really short acting opiates. They think that they know a lot about opiates in their body, but since the methadone is so slow acting, but it's cumulative, we have to explain that to them, that they're going to be waiting a little bit, and it's going to be sort of a delayed reaction to getting them to a dose where they feel comfortable. this statistically is when people are given too much at once and you can potentially overdose them. So we watch them closely. And by the way, I mean, talk about watching people. So just think about if you went to your doctor for a prescription and the doc saw you and wrote the prescription and handed it to you and it said it was one pill. And you're saying, like, you know, well, what do you mean one pill? What is that? And the doc would say, okay, well, there's your pill for tomorrow. And come in tomorrow and I'll give you another one. And that's essentially what we do, so that you're getting a script for the medication, you're being seen by a nursing or other medical staff or clinical staff every day, and then you're going to get your script. Let's see, we'll give you 6 pills if you are successful in this program for a year. So it takes our patients a year to even get 6 take-home doses of methadone. So the induction's very careful, and how soon we give medication out is very careful too.
Okay, so cocaine. We have done, as of August 30th, 4,868 tests for cocaine. We had 741 positives. This number is significantly increased over the last couple of years. We'll probably have 1,000 positives. Cocaine is cheap and powerful in Portland right now and very popular. Benzodiazepines, our biggest problem. So 4,746 tests for benzodiazepines, 495 have been positives. Dirty secret about this one is if you got a prescription from your doctor, that's not included. They show as a negative. That doesn't mean there is an abuse there. But this is one of the things we watch most closely. It's one of the very few times when we will discharge somebody for drug use if there's an issue with the benzodiazepines and we can't avoid the fact that they're a danger. We try to keep them, but this one right here is dangerous. So we watch very closely about it. Over the years, we've gone through a variety of different approaches to try to address this one. Dr. Pai will write letters to prescribers. Our nurse practitioner, Bonnie Plowman, will call them. She had the cell phone number of one of the bigger prescribers of benzodiazepines in Southern Maine and used to use that cell phone all the time to call them and say, what are you doing? So we try to watch out for this one. However, it is what it is. Cannabis. You'll notice a lot less. Some of that's because they have medical marijuana cards. Some of that's because when we admit somebody, or if they begin using it later on and tell us, I have no plans on stopping, we stop testing them for it because there's no reason to incur that expense. And it just annoys them because every month they have to come up to the admin window so we can say, your counsel will address this at your treatment plan. So we just stopped testing a whole bunch of them.
Did you read those numbers?
No. So 2,965 tests for cannabis, 1,140 of them were positive. The big lure on this one is if they stop using pot, they can have take-homes. Or as I read in the paper, I should say cannabis. If they stop using cannabis, they can have take-homes. So a lot of them will give it up for that. Okay, here's where we get hit hardest in the paper. We give them all 300, 400, 500, 600 milligrams. Truth of the matter is, 240 of our patients are on less than 50 milligrams. That's of a census in the methadone program of about, I think it was 630 today. 225 were 50 to 100. Recommended blockade doses 80 to 120. 138 were 100 to 150. 39 were 150 to 200. And 7 were over 200. Most of those are imports of ours, so we get them from other places, and it's we're not going to make them go down because I don't want to put them at risk. We talk to them.
Let me make a comment about that. So, if you were to ask addiction medicine specialists worldwide, what's the answer to the question, how much methadone should someone get? One of the top methadone dosing mavens in the world, his answer is enough. What he means by that is enough that it takes to suppress withdrawal and for them not to be intoxicated. So what we try to do is, we never know the answer to the question, how many milligrams of this medication is it going to take for a person to have the right blood level in their system? And we have very small people who are on interestingly higher doses and very big people that aren't. And the range, in my experience, of methadone that has adequately been suppressing someone's withdrawal, they're able to do whatever they want to do, they're not intoxicated by it, ranges from about 20 milligrams to, I had someone on 800 milligrams. So, I mean, there's a big span and a lot of individuality.
Okay, so when I did this, we had 613 patients. 429 of them were on less than 100 milligrams. 184 of them were over 100 milligrams. Before I go there, what isn't calculated into this is that we do clinical stuff as well. When people struggle, it doesn't necessarily mean they're struggling because they don't have enough methadone. It may also mean that they're struggling because they don't have enough counseling. So the first thing we do is we increase their counseling a bit. Usually they're okay with that. Sometimes they don't like that. Everybody's heard of the easier, softer way. Sometimes methadone can be used as that. We try not to let them get away with that. The goal is to make them whole and healthy, not just to get them to stop using. We shoot for the stop using first. The methadone helps us get them there. One of our biggest challenges in the state of Maine at all the clinics is being able to provide enough counseling with the limited staffing we have. When I became the director at Discovery House in 2009, I had 457 patients and I had 10 full-time counselors. A year and a half later, I had over 500 patients and 5 counselors. We went to 101, then we went to 150 to 1. The rate set by the state of Maine for Maine Care patients was $82 in 1994. When we went to 151, it was $58, and it was a lot more expensive to provide treatment. Everybody thinks methadone clinics, as one CARF inspector told me, are cash cows. And I said, obviously this is the first time you've been to Maine, because that's not the numbers I see. So I wanted to finish this off, and this is going way too quick, and we have way too much time left. So you guys are going to have to ask some questions. Less than 2 years in treatment, 64.5% of our patients. Discharges, 2018, as of August 30th, 318 patients. Drug testing, 5,817 tests. That's a lot of tests. Average dose, 83 milligrams. So if you take all the doses across the clinic, average amount, you get 83 milligrams. Counseling, this is one of the ones that really aggravates me too, is we don't do counseling. There was a really famous series of stories about somebody sitting outside of a clinic and counting or the minutes it took them to come in and come out, and use that to say that we didn't do any counseling. As of August 30th, we've done 5,530 hours of counseling. I don't have 5 counselors, I have a couple more now. Patient deaths. 2017, bearing in mind we were close to or over 700 patients in the 2 programs combined. We had a total of 11 deaths. Seven of them were for medical reasons. We had 2 overdoses. One of them was really a suicide. took an entire bottle of Seroquel. And we had 2 suicides, which is unusual. To date, or to August 30th, 2018, we've had 8 deaths, all of them for medical reasons. We have not had a single death related to drugs. And bearing in mind, that's with over 700 patients for the entire year. I think that qualifies as harm reduction. Questions?
Hi, I apologize if I might have missed this in the beginning, but could you just provide a little more context around, for those not familiar with Discovery House, kind of maybe what a typical intake would look like, or like you had mentioned, like by the second time somebody tests, they will, like something will happen, but how often are they tested? Like just some of the details around.
We test once a month.
Okay.
So the state requires. We test, they have what's called an NFT, nurse forced test. Which means if we suspect something, somebody presents as impaired, we get a report that they overdosed or something like that, we'll test. That's why the numbers vary. Sometimes we test for specific things on those. What an intake looks like. They meet with a clinician. That we have really good software, really speeds up the process. We can gather data quick now. The old company that owned us also owned the software, so it was in their best interest to give us some really good stuff. You can complete the assessment. Some of the counselors can do it in a half an hour. Most take about an hour because you got to do drug histories and all the psychosocial stuff. Then they will see one of our nurse practitioners or one of the doctors. That usually takes between a half an hour and an hour. At that point, they call Joe. Joe gives an order to dose them. Typically, we begin dosing at 30 milligrams. Unless there's something else going on, and then we'll dose them at a little bit less. You want to explain the increase, how we do it? Because it confuses me.
Not yet.
Okay.
Unless you really want to get into that technicality. The question really is about counseling. So,
Counseling. I can
we
do
do
that.
all those redundancies. The counselors are asking, I'm asking a lot of the same questions as the counselor when I'm doing my intake. And that's because, while people don't remember things, they're not sure that they want to disclose information, and I'm gathering information for another reason, and that is, should they be here, and what's their addiction severity like, what else is going on with them medically, what else is going on with them pharmaceutically, and how am I going to start them on a dose, and what do I need to instruct the nurses about, any tips about, as they're seeing them every day, what I would like for that particular patient. You were going to say something about counseling again.
We have 3 phases. There's in the SAM's regulations is 5 phases, but Maine Care went and changed everything. So now we have 3 phases. We have induction, stabilization, and maintenance. In induction, they do counseling weekly. That's going to be 45 days. There are actually some criteria to move them from 1 to 2. Which is a reduction in drug use and attendance and stuff like that. Then there's phase 2, which is stabilization. There's no time limit, there's no criteria, there's no nothing. It just says stabilization, bi-weekly counseling. And then they're in maintenance, which is counseling once a month. We do it primarily by group. We have been doing that for the last 8.5 years or so, since we had the first rate cuts and staffing reductions and stuff like that, because it's the only way we can handle that kind of volume. They do see them individually. We see them individually if they're pregnant, tapering, or struggling, if there's some crisis going on or something like that. They have access to counselors whenever they need them. We have more of a struggle of getting them to access counselors.
Well, actually, I was the counseling question, so I think you just answered almost all of it. But I would just ask, so you mentioned group, so at the beginning, so you said induction is an hour once a week,
Yep.
Stabilization is 45 minutes twice a month, and then it's an hour once a month. Is it group all the way? I mean, they have access to an individual, but is it mostly group all the way through, or one-on-one at the beginning?
I still have some, for a while, what we had to do with the induction patients is they had to do a group a week and 15 minutes with a counselor. I have counselors who still do that 15 minutes because they found it really helpful to the patients, because you get to, ask them how you're doing and what aren't you getting and what do you need. So I still have that going on, but mostly it's in groups, because like I said, if you're stable and you're not, in trouble, it's the easiest way for us to do it, and it's the easiest way for them to do it. I'm a firm believer that a lot of the counseling that's required for our maintenance patients is more or less punishment for still being on methadone. We have people who really don't like the idea that they have to go to counseling because they have their lives in order. Especially the people who've been stable and been in treatment for a while, they don't have things going on. They're regular people. We had one person who was in treatment for a very long time. Nobody in his family even knew. He would come in once a week, pick up his take-homes, and he would go live his life. And when you would come in, he'd want to talk to you about the Red Sox, and he'd argue about, having to go to counseling and how stupid it was, because he didn't have anything to talk about. If it were a fee-for-services model, I don't think the state would be insisting that we do it. But the methadone program is a bundled rate. The state gets it for free, and they're still on methadone, so they got to go to counseling. So.
I have a quick curiosity question and then another one. But you said you've seen an increase in the cocaine use. Have you also noticed an increase in methamphetamine use?
Absolutely.
Okay, good. Well, maybe.
maybe
not good, but I'm seeing that in our program, and so I was hoping that it wasn't just the population we're serving.
Oh, what
So it gives
program's
me
that?
hope.
What program's that?
The low barrier daily dosing at Greater Portland Health on Suboxone. For people experiencing homelessness.
I worked at Oxford Street on Saturday and Sundays for almost 10 years. I really wanted that 10-year certificate, but I didn't get it. And I work for the home team now on Saturdays, and I drive around town, doing what the home team does. And we watched, there still is, a medical practitioner who liked to prescribe Adderall and really gave them a taste for amphetamines. And now it seems like, the illicit market has just picked up, and it's dancing skinny people, lots of them right now. So
my real question besides that, though, was could you just explain what your taper process looks like?
When someone wants to decrease their methadone dose,
Or if they're being, if they're leaving the program based on multiple.
let's say
positive urines
someone's refusing to go to counseling, or one of the conditions of someone being admitted is that if they have a primary care person taking care of them, that we need to get them to give us a release so that we can contact them. It's just basic good medicine. That wasn't always the case in methadone maintenance treatment facilities for years. No one said anything about them being there. So if someone, people come in and they're in distress and they're suffering. And so we see them, one person sees them for an hour and a half, I see them for another hour, they have to sign a whole bunch of stuff. And we tell them what we're gonna do for them, and then they sign this contract that says, okay, I have to come in every day for X time, I need to go to groups, I need to submit urine drug screens, so on and so forth. So if someone, let's say, just is bagging counseling, they're not going. And we get together every week, a multidisciplinary treatment team, to discuss a whole lot of things. People that want take-homes, people that may not need take-homes, positive urine drug screens, problematic folks, successes, and we talk about all that stuff. So we don't want to discharge people. The stakes are high now with fentanyl. And how do you determine that the benefit that they're getting is more than the risk that we're taking if someone never shows up or we don't see them and we don't know how to dose them and we don't know where they are, they don't show up. It's really difficult to do. But I have to look at Basically, it's a medication, so I'm giving them a medication, so they really have to comply with the things that allow me to feel comfortable with dosing them. And if that's not happening, that's a higher risk than the benefit that they're getting. If one of the great benefits is seeing us, trusting us, talking with our counselors, talking with our other staff, if they're not showing up for that, what's the benefit of that? So we don't have cut and dry criteria. It's a really gray area. If someone is taking illicit benzodiazepines and they're coming to group and they appear like they're intoxicated, or one of the telltale signs is when somebody comes in to dose for the second time in the day and they don't remember the first time they dosed. If that's happening, we know then that they're not taking in a whole lot, even in counseling. So then we have to make a decision. Is it time for that person? We have a waiting list. Is it time for that person for us to discharge them and take them back in another 30 days? We do that. But the tapering process of the methadone depends on their dose. CSAT, Center for Substance Abuse Treatment, sort of that writes the guidelines for our federal regulations, really does not look well upon tapering somebody down in less than 21 days. And so we try to do people that are on higher doses, taper them down over 21 days. And very often when that person is notified of that, and during that taper process, a lot of times things happen. They begin to comply, so on and so forth. So that can be kind of corrective in and of itself. So it's called a medically supervised taper, and so I and the nurse practitioners look at that. But basically, we're plugging in around a 21-day taper for people. Does that answer your question?
Yeah, thank you. Could you speak to how you differentiate if somebody would be started on buprenorphine versus methadone?
Length of use, method of administration, quantity. We have a lot of people get themselves denied because they think if they say, I've done a lot, that they're going to get more from us when they get in, which doesn't help in either program. Most of them I see, and I know you're not doing 5 grams a day, you're not making $1,000 a day, whatever you're doing to get that money. I'm a big believer in motivation. So I take people into that program that I probably shouldn't. If they can show me that they mean it. I know of miracles. Mainly it's just that. IV drug users, it just doesn't seem to work. It just doesn't seem to give them the support they need to not use. And anybody who's taken buprenorphine knows that if I don't today, I can get high. And then you add in and I have something very marketable now that I can buy my drugs with. So we're careful about it, but those are the primary things. Sometimes if they're really persistent, I'll tell them, come in, or I'll have the medical assistant tell them, come in and talk to me. And oftentimes they can convince me, and it's all about that motivation. Because I think if you really, really mean it, then you'll get through that difficult period to where the buprenorphine is effective. Sometimes we'll tell them, come into the methadone program, keep your dose low. 30 milligrams of methadone seems to be much more effective for the higher users. And if they can keep their dose low for a couple of months and clean up their drug screens, then we can, transition them to buprenorphine. Because we found that when they're at 30, they lower it down to 15 or something like that, and then just take 2 days off, which isn't easy. Then they can safely transition. I'd like to talk about the tapering thing.
Hang on a second. So there are some relative contraindications to Suboxone that are sort of medical, and as we continue to use Suboxone, we see that those are kind of falling away. Used to be severe psychiatric illness. Basically what we're doing is we're saying we're putting in a less structured program here than the methadone treatment program, and we're giving you a script and then you're gone. And that from working in methadone for so long, where it takes a year for somebody to get 6 take-home doses, We know that even though it's safer, it's not safer for people who've never taken Suboxone, but there are some relative contraindications that a lot of people who have multiple chronic illnesses, we find we'd like to start them with more supervision to begin with, even though the methadone sometimes can be more tricky to dose. But it seems to be coming down to addiction severity, and that has to do with how long they've been using, how much tolerance. They used to tell us that the ceiling dose of buprenorphine, which is 32 milligrams theoretically, that was the equivalent of about 65 milligrams of methadone. Well, so you see our average dose is like 89 milligrams. So just from that, and that doesn't even hold up. We have people that are on higher doses than that do okay with Suboxone, so that shows you that it's a psychosocial, there's a multiple factors that influence how well someone's going to do. And it's mostly, if we're determining that the person needs to be tighter in their in structured program, we'll do that. But like Alex was saying, really what it comes down to, whichever a person wants to be in, we'll start them that way, and we can always, they're going to be seeing us, so we can work on them to say, well, maybe this isn't the best program for you, or it turns out that it is. So there's less relative contraindications that we have. People who have abused Suboxone, that's another issue, and people who are on higher doses of methadone or IV drug users, they tend not to do as well. Then there are people who are on higher doses, they taper down, brain changes occur, their life becomes different, maybe their life circumstances are better, then sometimes they can transition back onto Suboxone. It goes back and forth. I mean, to me, the addiction severity is directly related to the degree of poverty, and that addiction, the penetrance of addiction, how bad it gets to how many people, is directly related to the degree of poverty. So, you know, we're looking at all that kind of stuff.
So tapers, involuntary tapers, the counseling things and stuff like that almost never happen. Usually within a week of their dose being reduced, they'll do their counseling. That's a last resort. You really got to be behind, and you really got to refuse all of our entreaties to do what you're supposed to do. We almost never discharge people without a taper. We've had incidents where people violate some of the cardinal rules and you can't be here any longer. Almost always I will courtesy dose them someplace else to transfer. Sometimes that's a little difficult, but as far as financials, never less than 21 days. I'm going to take a hit on my AR no matter what, and my bad debt no matter what, so I'm going to give you the extra time, just hoping that you can get someplace else or you can figure something else out. As far as patients tapering voluntarily, it's absolutely individual. Some of the things we really watch out for are people going fast, because a lot of people will go quickly, they start to experience withdrawal, and what you got to remember is they may have been at one time really used to withdrawal and this being a daily thing to them, but then they have 2 years where they don't have it at all and they get a touch of it and it's horrible to them. We see a lot of people who will taper quickly, run into that, and then they get stuck. And that plan is gone because they're just afraid of that. So we recommend that you go slow and that you stop every once in a while and stabilize. I had a patient who was on 180 milligrams. He got this amazing opportunity to go to Europe. His brother was over there, an executive for some company who was going to buy him a Euro pass, and he was going to spend 3 months just traveling. But he knew he couldn't do that while he was still in treatment. He knocked the 20s off till he got to 100. He knocked 10s off till he got to 60. He knocked 5s off till he got to 30. And then he started going, I think it was 2 milligrams a week or 3 milligrams a week, and worked his way out. And that was, he left in 2004. I haven't seen him since. Well, not 2004, 2014, and I haven't seen him since. Actually, one time he showed up and tried to fix my phones, and I had to say, well, you can't fix my phones. They got to send somebody else, but he was fine. It definitely can be done. Long-term success depends upon the strength of your recovery program, though. You know, methadone doesn't fix you. You can't come in for 10 years or 2 years or whatever and leave and you're okay now. You need to do something afterwards, and that's one of the things we really struggle with as well.
Do we go till 2? Oh, okay.
So I do Suboxone as a primary care doctor, and I have had experience with a couple of patients who wanted to get off of methadone because of the counseling requirements, or they got a job and found it was just too stressful. And we struggle because they're often at that 60 to 80 milligram dose of methadone. And the goal was to try and get them down to 30 or 40 to then try and transition them to Suboxone. If you are switching someone from methadone to Suboxone, do you try and get to that 30 target, or?
Well, if I have the time and they're willing to get down to the lowest dose possible, I'm going to get them down to the absolute lowest dose possible if it's 0, and then do that. So times we can do that. If they have a time limit, then 30 for methadone off, 24 to 48 hours. Some people say 72. Most people do okay. I mean, by the way, we have people that come in and say, well, okay, what have you been using? I've been using Suboxone, okay, and I've been using heroin, and I've been using oxys. And one day I'll use the Suboxone, and some days I'll use heroin. And I mean, they're switching back and forth using them. And it's not like the package insert. So that's what I typically do, the least amount possible to avoid anything like that. And the least abstinent period possible.
So we worry about the period when they don't dose, of what they're going to do in the meantime. We've had a few who've transferred from the methadone program to the Suboxone program. And when we induced them, they got very sick, which means that basically they couldn't do the time without, so they picked something up on the street. When we first opened up the buprenorphine program, we had quite a few people transfer over. We had like 3 or 4 successes. We had a lot of them did well in the beginning, but as with the program as a whole, we've seen people kind of time out at a year or 2 on buprenorphine, and they stopped doing as well. And we had some people who were just stars for the first year, and everything came apart within the next 6 months. And we've had a bunch of people go where the buprenorphine just really wasn't working, and we got the methadone program right next door, right upstairs, and we moved them over into that. And we've had one who's came in methadone, went to buprenorphine, tapered off buprenorphine, came back and said, I need methadone, I've really been doing it up. And he's currently in the buprenorphine program again and doing very well. So he's one of the ones that makes me believe in the motivation, though, because this guy's determined. If I could just get him to give up the pot. Cannabis.
Hi. I've read a number of studies that say that women of childbearing age have better success on buprenorphine during pregnancy, lower NAS symptoms in the hospital, and lower hospital stays. How do you differentiate what treatment you're doing for women of childbearing age?
Well, you're talking about the mother study, and I don't know what other studies. And the mother study said that you're talking about the kids in the mother study.
I'm talking about the
Neonatal
kids.
abstinence syndrome. They had less abstinence syndrome. Absolutely, it looks like that's the case. But also, if you look at the study, there were more mothers who were on buprenorphine who dropped out of treatment.
I did see
So
that.
we asked them which they want, buprenorphine or methadone.
I'm asking how you differentiate what they should get when they come in, if it's a woman of childbearing age.
Well, we have 2 programs, and usually they want to come in methadone. Methadone's my more comfortable go-to because I have more experience that way. But in our 4-page informed consent, we have to talk to them about every modality and give them the pros and the cons of each of it. I mean, usually they say what they want, ahead of time, and now we have the freedom to be able to do that. We could put them in either. They are seen monthly, which either program that they're in, but that, in a nutshell, is how I determine who to take in.
Next question's over here.
Yes, hi. I have a question about policies and procedures around general hospital and stays in the jail when someone becomes an inmate. And I thought it might be helpful to suggest two scenarios. So one with the hospitalization, something that that we see sometimes. I work for Preble Street, and I work doing case management and connecting people to MAT programs. And a lot of times I see my clients have to go into the hospital for 6 weeks for IV antibiotics. And then for the other scenario, oftentimes too, I have clients who find themselves unexpectedly in jail for a short period of time. So what are the policies and procedures around hospital stays? And then for jail, upon release, how does Discovery House approach those situations?
Do you have a preference which one you'd like to take first?
Let me do the jail one. If somebody is arrested and incarcerated, and we know it, we suspend them. And typically we will leave them suspended for a month or more. If there's a release date in there, if we look at the inmate log and it says they're getting out, November 30th, and we haven't seen them in 30 days, we're gonna keep them. Because we know they're gonna get out, pretty good chance they're gonna come back. I also don't want them hitting the street after going 60 days without anything, because we all know what happens there. Hospitals, as long as they're in a hospital being dosed, they'll be suspended. We have pretty good relationships with all the hospitals around. We've had lots of those IV antibiotic people. The patient deaths, 3 of those 8 were infections on new people that, for whatever reason, didn't make it through the treatment before they passed away. But if they're in the hospital being dosed and they stay suspended until they're released, we've had people 120 days.
And if someone is in jail for less than 30 days, how do you anticipate their dosing? How many milligrams they're receiving when they return to Discovery House?
They'll go back to what we started them at, probably. It might even be a little bit less because now they're drug-free. So there's no real tolerance there. So, everything, all the things we've talked about as far as that stuff concerned is based on the individual. We get them in front of somebody, and we have a really good NP. And when somebody gets out of jail, she'll meet with them, and she'll talk to them, just like she does when she admits them regularly. So, they may, if they started at 30, they may start at 20 the next time when they get out of jail.
Yeah, just one piece about hospitalization. It's a federal law that if one of our patients goes into the hospital can dose them for a maximum of 3 days. And what we recommend to them is that they have to call us to verify the dose. A person saying, you're asking them how many milligrams of methadone you're on, and they're supposed to call us to verify that. That rarely happens locally. And then we'll find out a person's dose has changed, and they should be talking to us about it. So we send this 2-page paper, we give it to the patient or to the attending, that basically says, here, if somebody has take-homes, here's the responsibility in the hospital with their take-homes. This is what typically happens. This is how we monitor them once they're discharged. And then I have a little commentary about how to treat them for pain, given that they're with us. So we try to do the best we can to make this transition back and forth from the hospital. Well, if I had one complaint, it would be that often we're not called. When somebody's in there and they come back and they say, I had you on 90 milligrams. And they say, well, yeah, they were dosing me at 60.
We had one that was dosing at 70 milligrams. When she got back from the hospital, she brought her MAR with her, and they'd asked her, what's your dose? She said, 140. So she doubled her dose, and they listened to her, and they dosed her for, I don't know what it was, 8-9 days at 140, and she was really only on 70. So they never called us. We had no idea she was in the hospital, so she showed up with her paperwork.
Okay, we have time for one more.
Great. I was wondering if you could speak a little more to folks who have scripts for benzodiazepine and who are also being dosed with methadone or Suboxone, and some of the risks or concerns. I know that you mentioned kind of talking with doctors and when that occurs, but just kind of maybe the difference between the two.
Can I start this one? That wonderful software I was speaking of, when a patient reports they have a prescription to us, or when we see it on the PMP, we do a release. That release automatically generates a letter in the software saying what the patient's dose is, how long they've been in treatment, all that different stuff, which we automatically send off to their providers once that release is signed, so that communication is there. Speaking of the PMP, we check it at admission, anytime they request take-homes.
Define the PMP.
Prescription monitoring program. My nurse practitioner practically lives in that program. The patients hate it. What was the original question now?
Benzodiazepines, what do we do about them? Yeah. They're additive sedative, so we know that. It's problematic. I never know what methadone dose to put people on. I don't know how someone can predict what dose to put them on with regard to buprenorphine. We're kind of guessing. We don't know how much they're taking. There's short-term memory problems, so you can't really I can't really totally trust someone's script. It's a huge problem. With methadone, I'm almost forced to, if somebody's taking illicit benzos for a long period of time, bring them down to a dose of methadone so that they're almost practically in withdrawal. So they're going to be uncomfortable from an opiate standpoint while they're taking benzodiazepines, but I can't really do it any other way. But we don't kick them out because either we see them or they're on the street. So, we're taking them in and we're keeping them. But they're hugely problematic. So, lowest dose possible and try to be as safe as possible. No, I wouldn't think they're any less risky, yeah.
I have
So,
2 NPs
okay, 2
and
minutes.
2 doctors prescribing buprenorphine. Neither one of the 2 doctors will work with anybody with a benzo, licit or illicit. They just won't do it. One last thing. Probably 5 of those were administrative, other than financials, because we've had quite a few financials. We don't discharge for drug use. Almost every single time we'll meet with them, we'll meet in management, we'll discuss it, and we almost always come to the conclusion that they're better off with us than they are without us. So we keep them and we work with them, and we work with their doctors.
Thank you very much, everyone.